It looks like we're live. Good afternoon. Welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month, our topic is what is our topic today? What is infertility? That's our topic for today. This week is Infertility Awareness Week. And we would just like to bring awareness to infertility and all the couples who are both kind of suffering in silence and undergoing treatments, both who've started their journeys and completed them. And as always, we're open to taking questions and answering any questions or comments that you guys might have.
I'm Dr. John Frattarelli. This is Dr. Anatte Karmon.
Oh, I forgot that part.
Yes, from the Fertility Institute of Hawaii. Welcome, everybody.
So I think we can just kind of start out by explaining what is infertility. Maybe you can start us out with that. What is that?
It's difficult sometimes for people to grasp because a lot of people don't have infertility. They're just having trouble getting pregnant, and they call that infertility. And a lot of times it's just subfertility, or they're not timing things correctly. But really, infertility is defined as someone who's trying to get pregnant, typically, with a heterosexual couple having intercourse at the right time, who's ovulating, everything's appropriate for a period of 6 months to a year. And if you're not pregnant, then that would constitute being infertile potentially, or subfertile. But also infertility would be if your tubes are blocked, okay, or if there's no sperm, or there's a sperm issue, or there's a uterine issue, or any issue that deals with the reproductive function. That would also be a definition of having infertility and needing some assistance.
I also think it's just like you pointed out, it's important to note that most people with infertility are able to conceive. And getting treatment may help you along and may shorten the time interval to getting pregnant. But typically, there's no test that I can do to tell you for sure you're not going to get pregnant, with a few exceptions, right? If there's absolutely no sperm, if there's no uterus, that sort of thing.
But even then, people have options, right?
Right.
Because even if there's no sperm, that doesn't really mean there's no sperm, right? So if there's no sperm in the ejaculate, you can sometimes get sperm from the testicle, and so you can use donor sperm. But having sperm in the testicle is an option for a lot of men who have no sperm in the ejaculate. And for someone who may not have a uterus, a gestational carrier or surrogate is an option. If someone doesn't have, if there's an egg issue and they don't have any eggs, they're a little bit older, or they have diminished ovarian reserve or ovarian failure, they can use donor eggs. So there's typically always, and I think we always say this to our patients, there's typically always a way for someone to achieve their dream of having a family. It may not be in the route that they initially thought, but the ultimate goal is to have a family and to have a child, and most people can achieve that if they really go through all the steps and if that's what they want to do.
Yeah, and especially in 2022, the technology has come very, very far. And so all of the really complex types of treatments that were extremely expensive and just basically unavailable to most people are now both more available, more successful, and many of them are also more affordable. So, for example, utilizing donor eggs is not all that uncommon. And allows women who otherwise wouldn't have been able to conceive using their own eggs, they can now typically carry a baby and have a child of their own. Donor eggs used to be extremely expensive and really only available for the people who could afford it. But now with the advent of donor egg banks and other types of kind of shared donor egg type of cycles, many people who otherwise wouldn't have been able to do these types of cycles are now able to do it. And in fact, some types of donor egg cycles are actually the same cost as doing an IVF cycle yourself, but more successful. And so I definitely urge people who know that they have an issue with their eggs to kind of come in and talk, especially if it's been a few years since they thought about it. But I do want to kind of bring up an important point that I was trying to get to, but then Dr. Frattarelli sort of interrupted me in the middle, which he often does during these.
I just like to get a word in sometimes.
But what I wanted to bring up is that some people are very hesitant to come see us because they're worried that I'm going to say, "I'm sorry, you just can't have a baby." And I sort of want to explain that there are very few conditions where I would say that naturally. I mean, obviously, as we discuss, even if you don't have a uterus, you can still have a baby using surrogate. But there actually are very few conditions where you simply cannot ever get pregnant naturally. And sometimes all you really need is just some help. Things like ovulation induction, which oftentimes just taking oral medication. To help stimulate the ovaries, things like intrauterine insemination, which is just taking sperm concentrated, putting it directly into the uterus. These are not exactly completely natural, but minimally invasive and simple approaches to kind of help you along. And so oftentimes that might be all you need. Other times we really don't find any issues, and you might be sort of young and just starting out in your fertility journey, and we might decide that maybe just taking a little bit more time is what you really need to do. So I think that people sometimes in their heads sort of make up the scenario where they're going to get very, very bad news. And that's really not the case many of the time, and in fact, most of the time.
I think a lot of times patients will wait because they don't want that bad news,
Right.
and then come in 2 or 3 years later than they really should have, and certainly the news can be worse then. So certainly coming in sooner rather than later, even if you're not really ready for treatment, just to see what might be going on and get possibly a diagnosis or evaluation, and maybe some tips on how to improve just natural fertility, earlier on would be useful for most patients.
So I think an important question that we may have sort of answered already is, when should you consider evaluation for infertility? And so that is going to be different for everyone depending on your case, but typically 6 to 12 months of trying to get pregnant and not achieving a pregnancy. So if you are female, 35 and over, then you shouldn't wait a full year. You should come in at 6 months. If you're under 35, you can wait a year. But if you know you have a fertility issue, you know that you have a male partner who has a low sperm count, or you have a history of endometriosis, or you have irregular cycles, you have blocked tubes, those types of things, then you should definitely come in earlier. There's really no need to wait 6 months before coming in. And then, of course, there are patients who need fertility treatment for various other reasons unrelated to how long they're trying to get pregnant. For example, women or men who are in same-sex relationships. Obviously, there's really no need to wait. If there isn't a sperm or egg source, then you can sort of come in right away, and we can help with that as well.
Also, single patients as well, and I think that the other thing is, if you think there might be an issue, then just come in, whether it's been 6 months or a year, or whether there's an issue or not. If you just think there might be a problem, then come in, and it doesn't hurt to have an evaluation. And coming in these days, a lot of times, is really just making an appointment and doing a telemedicine visit over the phone, and then coming up with a plan for looking at what diagnostic test that we need to do. And I guess I can go ahead and kind of talk about that a little bit. For the male, it's pretty it's pretty simple. It comes down to sperm. So we just get a sperm test and maybe some blood work, depending on what the male's history is. And obviously, we also get a history and ask them about medical problems and medications and things. For the female, we do the same thing. We get a medical history, and when we're talking to the patient. And then for the female, it's a little bit more involved, because not only is there an egg, but there's ovulation, and there's fallopian tubes, and there's the uterus, and there's carrying the pregnancy afterwards. So the evaluation is a little bit more complicated, or a little bit more tests, but it can happen pretty quickly. We can do it in basically 2 visits. We can do everything that we can do actually in 1 visit, typically right after the menstrual cycle, we'll do what we call an ultrasound, which is a saline ultrasound at the same time, where we look at the cavity of the uterus, make sure that there's no polyps or anything inside the uterus, no abnormalities inside the uterus that would prevent a pregnancy or cause a miscarriage. We look at the uterine structure, see if there's fibroids, make sure the uterus is nice and healthy. We also get blood work at that time for reproductive hormones. And we look at the ovaries with the ultrasound too, to see how many follicles and how healthy the ovaries look. The ovaries are going to look different at different stages in somebody's life. 22-year-old ovaries look different than 32-year-old ovaries, look different than 42-year-old ovaries on average. And so we're able to tell, okay, is this your ovaries look, appropriate for your age, and sometimes better or sometimes worse, but that can help with the fertility evaluation. And so you can do all of that basically in that day 5, 6, 7 of your menstrual cycle and have almost all of the infertility evaluation completed. The only other thing we would need to do potentially is a hysterosalpingogram, and that's the other thing is an HSG, where the radiologist puts a little catheter into the uterus, and some radiopaque substance into the uterus goes into the fallopian tubes, and under real-time fluoroscopy, the radiologist and yourself typically can see if the fallopian tubes are open. And so, within 2 weeks of your menstrual cycle starting, your evaluation's done. And then you do a follow-up visit with us afterwards, typically by phone, and we go over everything that we found and talk about what options you have, what issues we found, things like that.
I think we can also take a minute to kind of go over natural fertility and the menstrual cycle, because a lot of patients have that kind of question too, like what can they do to optimize fertility? So if you're kind of heterosexual couple things to keep in mind. If a woman's cycle is regular and approximately 28 days or so, then she'll usually ovulate around day 14. And not necessarily on the exact same day, but somewhere around there. The fertile window is a few days prior to that day 14. Okay, so you want to be sure that you're having regular intercourse prior to that. And so we usually kind of say timed intercourse starting somewhere around day 12, or you can start a little bit earlier, every other day for about a week. Is going to make sure that you're in that fertile window. You can use something called, and for example, an LH kit, which will actually check your ovulation time in a little bit more of an accurate way. But if you're kind of getting in intercourse around that time, then it's not that helpful. I think it's more helpful for people who are having infrequent intercourse and people who really need to know the window because of travel plans and things like that. Then that might be helpful. But you don't have to monitor your ovulation if your cycles are regular and you're kind of getting it in around that time. The other thing is, having sex every day versus every other day have roughly similar, for people who have normal sperm count, roughly similar success rates. And so there's no need to have sex every day unless you want to. You can do every other day in that kind of fertile window time period. People also ask about lubricants. If you do need to use a lubricant, there are some that are safe that are marketed for sperm, meaning that they don't kill sperm, right? So I think pre-seed is one of them, or you can use canola oil, which just cooking oil. Don't just use any cooking oil. Use canola oil if you're going to do that, or one of the lubricants which are safe for sperm, like pre-seed. Most of the lubricants that are sold in stores as lubricants, like KY jelly, that sort of thing, they're a little bit spermicidal. They're not great for sperm, so be careful with that. And then the sort of typical things of living a healthy lifestyle have also been shown to be helpful for fertility. So being normal weight, which is, as we all know, easier said than done, and cutting down on caffeine. High doses of caffeine, even pre-conception, have been linked to miscarriage. So that's kind of where that recommendation comes from. And then avoiding excessive alcohol. Cigarette smoking is a big one, actually. Very, very strong link between cigarette smoking and conception. and that's through multiple mechanisms. It does seem to impact both male and female fertility. It does impact ovarian reserve over time. And so definitely cutting back or quitting smoking altogether certainly is recommended. And then, drug use, we don't have a lot of data for obvious reasons, a lot of studies about the impact of drug use on fertility. So, we obviously just say to try to avoid it. And then for men, I think that there are there are also some recommendations, but the nice thing with men is that they're always producing sperm. Sperm cycle is about 3 months. So if you're kind of getting into a healthy lifestyle, you may not expect to see changes for another 3 months. So keep that in mind. But the same sorts of things that I mentioned about female fertility also apply to male fertility in terms of being overall healthy. Having a normal BMI, being overweight for men especially can impact hormones, and it can impact estrogen, testosterone levels, and sperm production. So that's definitely important for sperm production, as well as cigarette smoking, drug use, and that sort of thing too. And then kind of frequent ejaculation. So like I said, having sex every day or every other day around the time of ovulation is also good for sperm. You don't want to sort of abstain for too long, because abstaining for too long may also not be great for the sperm quality as well. Treatments, you want to go through?
Sure. So depending on what somebody needs, and as Dr. Karmon said, it can just be natural. I mean, if you're sometimes it's just educating somebody about their menstrual cycle, and when they're ovulating, tells them everything they need to know, and they get pregnant within a couple of months. And in general, if everything's working appropriately and you're having intercourse at the right time, really 3 to 4 months, most people are going to be pregnant. Okay, we say 6 months because we realize it doesn't always work. The timing's not always there. But certainly most people are going to be pregnant within 3 to 4 months if everything's working appropriately and you're having intercourse at the right time and ovulating. But as far as treatment, it depends on what we find. If for the male, the treatment, and I guess first of all, there's only so many ways to get pregnant, right? You got to get the egg and the sperm together. So how do you do that? You either have intercourse, or we put sperm into the uterus with what we call an artificial insemination or intrauterine insemination, or typically IVF, in vitro fertilization, where we take the eggs out, put the sperm into the egg, and then let the embryo grow in the lab, and place the embryo into the uterus. So there's really only a couple ways to get the sperm and the egg together. But for men, if there's a sperm issue, you can do, and there's sufficient quantity and motility of sperm, you can do IUIs, or intrauterine insemination, where you get a sample, you wash the sample, and you put the sperm pellet, just the sperm, inside the uterus. And what you're doing is you're bypassing the vagina, you're bypassing the cervix, where you lose a lot of sperm, and you're putting about 20 times more sperm into the uterus than gets into the uterus with intercourse. So 20 times more in the right place at the right time gives the egg a better chance to get fertilized. For females, if there's an ovulatory issue, there's medications that we can use. There's oral medication and injectable medication, depending on what's needed. Depending on the hormone levels, there might be a thyroid issue that we need to correct, or a prolactin issue that we need to correct as well. And then, with ovulation induction, or giving medications to women to help them ovulate, you can either do intercourse, or you do IUIs, put sperm into the uterus. And then if none of that's working, it's IVF. So typically the treatment protocols for patients, if you're wanting to get pregnant, it's 3 to 4 months of intercourse or IUI cycles with ovulation induction with medication. And then if that doesn't work, you're talking about IVF. Doesn't mean you have to do IVF. You don't have to do anything. It's really the fertility journey that it's important to realize. The fertility journey is not mine. It's not Dr. Karmon's, right? It's yours. And so, we're here to help. And wherever you want to go, however far you want to go, however long you want to take, we're here, just here to help you. But typically, if you're not pregnant within 3 to 4 months of a treatment, it's time to at least talk about moving on, because that treatment, you've had your best chance. And so that would be IVF, in vitro fertilization, afterwards. That cures a lot of things, because what we don't know is what's happening at the fallopian tube, in the fallopian tube with the egg and the sperm, during fertilization. And so with IVF, by getting the eggs out, looking at the eggs, which finally we now have the ability to do, we can then put the sperm into the egg, make sure that every egg gets a sperm, and then watch the embryo grow and see if we're getting good fertilization, if we're getting good embryo development, get a lot more information, and then place the embryo into the uterus. And there's a lot of other things that you can do potentially with IVF that maybe I'll have Dr. Karmon mention here in a few minutes. But that's kind of typically the basics of what we would typically do. And obviously, if that still doesn't work, there's other things that you can do as well that we'll move along to as well. But what about with IVF? For you, Dr. Karmon, what about for IVF? Somebody who's doing IVF, what are the other things that they might need to be aware of or know? Or somebody that's doing ovulation induction, if I didn't mention something that you want to bring up.
Well, I guess that there are two, like you mentioned, there's kind of these two big categories: ovulation induction, IVF, and then within that there are lots of different options to discuss. So it's not just sort of one thing, but it's kind of these categories. So with ovulation induction, there's the oral injectable medication, and with IVF, there are a lot of different protocols and treatment options for sort of various etiologies of infertility, or when we think that there are different kind of issues, we sort of personalize the protocol for you. So for example, for most patients who are sort of respond well to IVF, we expect that their hormone levels get very high during the cycle, but then those high hormone levels can actually harm implantation if we put an embryo into the uterus right away. So for that reason, we actually freeze embryos and transfer them later. That's called a frozen embryo transfer. And so we do that for the majority of our patients at this point, but mainly for the purpose of trying to optimize implantation rates in those people that would benefit. And then there are all types of other things that we can consider, for example, genetic testing, especially for women who are 35 and over, for women who have a lot of embryos, or for women who have a history of miscarriage. Doing genetic testing can help us choose the best embryo in a cycle and help us kind of hone in on which embryo is actually going to be the most likely to implant. And so that's also kind of a choice that we discuss with you, and and may or may not be the right one for you. And there are all kinds of various medications which we can kind of sometimes add. And there are patients who have certain issues, for example, endometriosis. We might want to suppress the ovaries for a longer time doing an embryo transfer. So there are just so many things to consider, both clinically as well as in the lab. There's certain lab procedures. There's something called the zymote, which can help us can help the lab personnel choose the best sperm, and that has been shown to improve outcomes, decrease rates of miscarriage as well. So I think that it's just important to know that although there aren't tons and tons of category treatment options, there are just so many protocols that are kind of personalized to the individual patient.
Correct. Yeah, I think that's a great point. So again, only so many ways to get the egg and sperm together, but in getting the egg and sperm together, different ways of different protocols for medications and everything that the patients may need or require, depending on what your diagnosis is. And also to realize that here in Hawaii, a lot of insurance programs will cover the majority of what we've spoken about. Some insurances will cover. We're a mandated state. We're one of maybe 15 mandated states now. Initially, I think we were like the second or third state that mandated IVF coverage for insurance back in the 1980s. But now there are like 15, I think. But as part of IVF, all Hawaii-based insurances have to cover IVF, but they don't necessarily have to cover other things. And so you'll have to look at your insurance to see what else they cover. Some insurances will cover the IUIs and the ovulation induction process before IVF. Some will not. And that's something that we certainly discuss with you, and we find out immediately when you make an appointment, so that you're aware of what options you have. And for these treatment options that we're talking about, it really goes for everybody, whether you're a same-sex couple, whether you're a single patient. It's still getting egg and sperm together. And so if you need sperm, we have to use, we'll use donor sperm, and there are donor sperm banks that we can use. Sometimes people will use a directed donor, somebody that they may know. And if you need eggs, there are egg banks, there are egg agencies, there are egg donors that you utilize in order to get eggs. And obviously, then if you need a uterus, there's a surrogate program, so that you can use a gestational carrier surrogate. Same thing, where somebody carries the pregnancy, and then once they deliver, the baby comes back to you, and you obviously are kind of going along with the journey with the pregnancy as well, typically, going to OB visits and interacting with the surrogate, on a daily basis throughout the process.
Yeah, so I think that sort of sums up most of the treatment that we wanted to discuss. I think we didn't really touch too much on the causes of infertility. I think we can kind of briefly go through that. So every kind of body part that's related to the reproductive tract can sort of go wrong and give us some trouble. So in terms of ovulatory function, sometimes having irregular cycles can be related to a condition called polycystic ovary syndrome. Oftentimes the treatment for that is just to stimulate the ovaries. Or ovulatory function can be affected by having a low ovarian reserve or low egg count, either due to natural aging or kind of other reasons. Or something called hypothalamic dysfunction, which is common among sort of athletes, where your brain kind of doesn't really signal the ovaries to release eggs. And so all of those actually are, we like seeing polycystic ovary syndrome and hypothalamic dysfunction, because oftentimes those are the sort of easier ones to deal with, and usually we can get away with pretty simple therapy for that. Endometriosis is another one. I mean, each one of these topics we have a whole Facebook Live session on, so I won't get too into it, but just to kind of go over some of the more common ones you might hear. Endometriosis is one of them that can impact multiple factors, can impact the ovaries, fallopian tubes, tubal factor. So, having your fallopian tubes blocked for other reasons. You can have one tube blocked or both. And of course, male factor, if there's an issue with the sperm, whether that's kind of having a low count or low motility, issues with the shape of the sperm, all those things can impact fertility. And then in terms of uterine issues, there are very simple uterine factors sometimes that we can easily fix, like, for example, uterine polyps, which are just little overgrowths of the lining. We can remove those, and that can help to improve fertility and decrease miscarriage rates. Uterine anomalies, so abnormally shaped uteruses, those sometimes those can either be surgically corrected, or sometimes they don't have to be, depending on the anomaly. But again, we do see higher rates of miscarriage and infertility with many of those. And then, everyone's favorite, unexplained infertility, which just means that, yes, you have infertility, you're having trouble getting pregnant. We recognize that you need treatment, but we don't know exactly what it is that's going wrong, because there are things that we can't test for. We don't really see inside the body to see, are those little eggs and sperm coming together? Is there an issue with implantation? We're not seeing all that. That's sort of the bad news. The good news with unexplained infertility is there's a lot of research behind it. It's a diagnosis in and of itself, and there are proven methods of dealing with it. Ovulation induction, in vitro fertilization, all these things have been shown to be successful for people with unexplained infertility. And lastly, actually combined factors, which is way more common than you might think. And oftentimes the way that I look at it is, well, somebody might have, if a female has kind of a mild issue, that may be easily overcome if there were no issues on the male's part. But if there's kind of a mild female factor and a mild male factor, that can come together and create a larger issue. Or if there are a few mild female factors or something like that, a few mild male factors, those can again come together to create a larger issue. And obviously the treatment's going to depend on what factors we find. But that is also one of the reasons why I say, even if we find a male factor, we still need to do the female evaluation, and even if we have a known female factor, we still need that semen analysis, because a lot of times we find issues on both ends. So.
And it's not uncommon that you'll have a patient who will have fibroids, a uterine factor, have endometriosis, have PCOS, polycystic ovarian syndrome, where they're not ovulating as well. So, and even have maybe a block 2, have almost everything affected, and have the male with low motility or low number. And those patients still have, depending on their age and their egg quality, still have an excellent chance of getting pregnant. And I guess one of the things two things I meant to mention earlier was when you look at what it takes to make a baby, egg, sperm, uterus, right? But those are the 3 things. It's 90% egg, right? So you got to have a good egg. You can have sperm that's just almost dead, as long as the DNA is there, and as long as it's wiggling and not a dead sperm. That sperm can make a beautiful baby, because all we're using with the sperm is just the DNA from the head of the sperm. And then the uterus, as long as it can carry a pregnancy, is fine. But it's really that egg that really determines the outcome more than anything. And then the other thing I wanted to mention, which is pretty common, it's very common these days, is testosterone treatment for men. That is not helpful for fertility, and I think that's kind of a being more and more known these days. But I think it's still not realized that it does just dry up the sperm. It causes the sperm production to decline, to finally stop after up to 3 to 6 months of therapy. You may have no sperm being produced. And if you stop the testosterone production or to start testosterone injections, that doesn't mean it's going to come back. It may come back in 3 months, 6 months, 2 years, or it may not. Everybody's a little bit different. And so that's always something that you should be aware of too. If you're wanting to conceive in the future, if you're trying to get pregnant, don't take testosterone injections. And if you are, certainly stop and come see us.
Yeah, there are some medications which can increase testosterone in a secondary fashion, and those might also improve sperm count. So there's a medication called Clomid. I mean, these are not medications that are typically given to men long term, but they can kind of improve fertility and also increase testosterone levels. So there are some other options other than just testosterone if you need it. So, all right. Well, I don't know. That's it for now. I don't think we had any questions. I see that we have somebody who mentioned that she is wearing the bracelet that we are kind of handing out in the office. So if you're our patient, come stop by and we can give you some goodies for Infertility Awareness Week. And we definitely urge you guys to tell your stories, obviously whatever you're comfortable with. But I think the more people kind of share their stories and normalize infertility, the more people will be able to kind of just have the strength to seek the treatments that will really help them build a family. So I think that's an important thing to end with.
And I think that along those lines, I mean, this along the lines of telling your story, and I've done this before, but the reality is everything we've talked about, I had to do in order to have my 4 children. We did IUIs, we did IVF, and we used a gestational carrier for our last child. And so, without the technology of what we do, I wouldn't have my family. And so, so it definitely is very personal to us. And I think that, I'm very happy to always talk about that. I love my children, I love my family. And I think that any way that we can help you, any patient, that really is our job. And it's not even a job. It's really, it's kind of a hobby, and it's fun for us to do, and it makes us happy. I had twins come see me today. It was just, just brightens our day to see the outcome. So thank you guys.
Yeah, thank you for trusting us with your journey and giving us a few minutes of your time to listen to us talk about fertility. So we'll see you guys next month. All right.
Aloha.
Mahalo.